Dr. Kikkawa, someone has had a myectomy and now has apraxia of lid opening. What would you suggest?
I think if it's true eyelid apraxia, I would certainly want to know how much the effort is to lift the eyelid. Most of the time, if it's severe apraxia, frontalis suspension is something we would consider. If it's just a mild case, you might consider trying an eyelid tightening procedure, but we certainly would just want to make sure that there's an adequate dose of neurotoxin to block any residual blepharospasm before considering any eyelid opening procedure.
All right, I have 3 quick questions for the panel. Is pain in the right eye related to blepharospasm?
Well, blepharospasm purely by itself is not felt to be a painful disorder, but you'd have to look into all the reasons that there could be pain, like as the hypothesis lead us, irritation of the eye for whatever reason, and sometimes that is pain, can lead to changes in how your blink behavior might be, and that may set in motion speculatively the things that may be associated with blepharospasm. So it's something that you have to take into consideration in the context of the individual patient.
But it's not from the blepharospasm per se, it's from an effect of the... Right. Likewise, is memory loss related to blepharospasm?
That one I can't think of a pathophysiological link between the two.
Ben, memory loss?
I don't remember.
You don't remember, okay. How about sensitivity of your tongue to food?
That's fascinating.
That's fascinating.
That's, the patients come up with the neatest chief complaints. The tongue is a really highly innervated organ with lots of sensory input, and it wouldn't surprise me that some people have sensitivity to things. If you are sensitive from the eye point of view and you have tongue sensitivity, I think that's an interesting observation that, again, we'll be learning from for you. But I don't have anything to add beyond that.
So I take back my previous statement. If you're a plaintiff's attorney, you should contact Dr. Wu. Dr. Kikkawa, what is the success rate of myectomy, the limited myectomy? You said you don't do the complete. And what is your definition of success?
That's an excellent question. I think, I would say most of the patients, and I think you have to define success. Will it, is there a high probability that you will go from non-functional to functional? I would say yes to that. It's probably not 100%, but it's probably in the order of 80 to 90% that it will improve the condition. It will likely reduce the amount of botulinum toxin or the neurotoxins that are required, but most people will still need injections. And the myectomy is not something that's for everyone. Like I mentioned earlier, it should be considered a last resort procedure where you're not able to be controlled, your symptoms are not controllable with medication. But I would say for the most part, patients who've had it done, and I think there are probably several people in the room that may want to comment if that's possible, Peter, to have patients just give their experience, because I think there are some downsides that I tried to cover. For example, the dryness that may occur, the incomplete closure, but I would say by and large most patients do have a significant improvement.
Okay. A couple of questions just on technique. Dr. Frishberg, do you use any anesthetic before you inject amylo cream, ice? What do you do?
I'm not very nice. I don't.
No, you're not. Right. Don, do you?
I usually individualize patient by patient and ask if they are sensitive to the injection. Some are more sensitive than others, and those patients will offer the topical anesthetic, but some patients that aren't sensitive, we don't apply anything.
I generally don't, but if they're sensitive, I'll use some ice on it beforehand.
I tailor it to the patient, some ice, some nothing, and some topical anesthetic. I have one patient that actually takes a low strength narcotic when she arrives in the clinic, and then I put anesthetic on, and primarily that's to treat me, because otherwise...
Do you give her general anesthesia too?
Otherwise, otherwise it's too painful for me and for her.
Yeah, I offer it to the patients, and some of them take it, some of them don't. So I think that most people do that. Another sort of technical question is why, if you're using Botox, why can't you, to treat blepharospasm, why can't you use the 50-unit Botox cosmetic so you don't have as much wastage? Russ, you want to take that?
Well, I'm the one who submitted the question. I don't
Oh.
know. I can tell you that that's what the reps have told me. I didn't know if maybe Don or Ben can answer that question. I've been told that CMS would be asking you to.
Yeah, you can't bill the NDC number.
With an NDC number.
Well, there's something about, well, at least I've been told by Allergan that if you bill the cosmetic, they won't pay you. I think there is something on the billing that has, yeah.
No, you put a J code in, and it's all
Someone's probably doing it on the back end.
So the
They
answer
claim
is
it's
it's all
not
about
kosher.
money,
I'm pretty sure.
like of many things in life. I think that
Yes, exact same.
it's the exact same drug, but it's labeled differently. And then it becomes problematic to get reimbursed when you bill it. Why it was labeled differently, I don't know. Okay. Don, are frontalis slings for severe apraxia contraindicated after a limited myectomy with lagophthalmos?
The answer to that question, I think, there's no absolute answer. I would say it should be looked at on an individual basis. If there's severe lagophthalmos, then I would say probably the sling is not the best procedure. If it's a mild lagophthalmos, I've done slings after patients that have had myectomy with a small amount of lagophthalmos. You know, the band is titratable, it's adjustable, so it's not usually an all or none procedure. When we do a frontalis suspension, we can adjust it. If it's too tight, we can give a little bit of anesthetic in the office and loosen it. If the eyelid doesn't open enough, we can tighten it. So that is an advantage of using the silicone material. It is adjustable, so it can be titrated to the amount of lift that's required.
Okay, this is, I would have thought my wife wrote this question. Are there things that I can do after getting injected? Sitting, don't rub your eyes, don't lie down. This is the information she gets out of her magazines. You know, this is what the cosmetic surgeon in New York is doing and charging $5,000. It's that you can't rub your eyes, this, that, and the other thing. Do you tell people? You don't tell. You tell people do what you want, right?
Well, no, I tell them not to rub their eyes, not to get a massage that day. You can move the toxin around. So if you start rubbing your eyes and massaging it around, it could be a problem. But after probably 4 or 6 hours, it probably doesn't matter. I don't tell them not to lie down. I know other people do.
Do you tell them anything specific?
No, I don't in terms of lying down either, but I think if you're, bruiser, obviously in that case, ice probably would help, both before and after. So if you're concerned about, a little bruising that occurs, I think ice is definitely helpful in those instances.
I don't provide any particular
Any
instruction. but
peripheral
now
instructions?
Now I'm going to tell them all about dry eye.
I tell them not to take a nap, because the stuff can diffuse, and if they're laying on one side, they may get a differential effect between the two eyes and not get a good result on one side or the other.
Parenthetically, the questioner asked, will today's PowerPoint presentations be available on the Blepharospasm website? Actually, they should be on the DVD, right, Marilyn? Yeah. Let's see. Are there any nutritional factors triggering blepharospasm? Omega-3 fatty acid, vitamin D, vitamin B12, zinc deficiency, etc. Anything that you all know of that?
Nope. Nothing specific.
Do you routinely advise people to discontinue blood thinners before you, or vitamin E or something like that before you inject them?
I think it's probably a dangerous thing to advise people to discontinue blood thinners. It depends why they're on them. I have patients on Coumadin that I still inject, and they don't have much of a problem. People are on blood thinners usually for a good reason.
Yeah, I think that's right. I mean, you're injecting, I usually use a 30-gauge needle, and that if it causes a little bit of bruising, I don't know who mentioned it before, but you take the needle out and you see, oh my God, you're going to have a black eye. You sort of put pressure, you put ice, and you hope for the best.
So what size needle did you use when you did your wife?
Huh? No, the analgesia I use on my wife when I inject her is I take a Valium. All right? Dr. Wu, what effect does age have on the blink function?
That's a really interesting question. The prevalence of blepharospasm goes up in the older ages, and I think among the focal dystonias, blepharospasm is one of the higher age ranges. And we know that dopamine neurons actually do decrease with age. And even though it seems very independent and not Parkinson's disease, there is that one hypothesis that a slight reduction of dopamine increases your blink reflex excitability. And so I've always speculated that that might have something to do with the increased prevalence of blepharospasm in that group. But as a clinician, it's just an increased risk.
Okay, this is a patient who, again, what we've talked about before, it says, Botox didn't work for me. They've also had a limited myectomy. First of all, how do you verify that the Botox really isn't working? And I think we addressed that. Because if your lids are not opening, it doesn't mean the Botox isn't working, because it could still be weakening your muscle, and you might have apraxia or something else. So what should I try next? So that's really, I think, the pertinent issue. If somebody has had limited myectomy, and I agree with Don that most of the people who have the limited myectomy, they have it not, and after that, it's not that they don't need the Botox, it's that it will then work again and make them functional again. But how do you verify, what do you do next if someone comes in and says, I've had the myectomy, Botox doesn't work, which let's assume the lids are not opening. What's your next step, Russ?
Well, one thing I would do is just make sure there's not other local eye issues. Make sure that the dry eye is being treated if it's there. Make sure that any blepharitis is being treated. Discuss with the patient the use of blue blocking lenses or other lenses if light sensitivity seems to be a large part of it. I'd also find out what they mean, as you said, isn't the Botox working? Is it really that they're still having lid spasm, or are they staying closed?
Well, that's my point. I mean,
if they're
what would
staying
you look
closed
at?
and all of those things are under control, then a surgical option like a sling might be the right answer.
All
But
right,
I would
so-
look for all of those other things, and I think most blepharospasm patients, I think, have some component of dry eye. Most of them have some, many of them at least, have a significant component of blepharitis.
Well,
Those
but
things should be
let me play devil's advocate. You think that after a myectomy, that blepharitis or dry eye alone can result in the patients not being able to open the eye? Even
I
if they
don't-
have blepharitis?
Right. I don't think that the blepharitis or dry eyes makes them not open their eyes, because first of all, a lot of people in the population have it, so it's just so common, and then also it doesn't have an impact on opening.
Okay. So, Don, this patient comes into you, can't open their eyes, they've had a myectomy. Do you do anything else before recommending a sling? I mean, do you try Botox again? Do you try a different toxin? What do you do?
Yeah, so one thing I didn't comment on in my talk was that I do change the injection pattern after myectomy. And usually there's no need to inject the upper eyelid anymore. Because we remove the muscle, most of the targeting now is going to be on the lower eyelid and possibly still a little bit in the corrugator area and the outer portion of the lower lid. So I would, try to investigate what the new pattern of injection is. And there are some patients occasionally that still require up to 100 units, even in the lower eyelid. I've done myectomy. I know I still give patients some up to 100 units, just, targeting different areas. So I would make sure they're on maximally tolerated neurotoxin before considering any other surgical procedure. And then, the diagnosis of apraxia is really a clinical diagnosis. And I think, for seasoned clinicians, it's usually very, I wouldn't say it's easy, but you can usually make the diagnosis by examining patients. So I would just, possibly maximize the neurotoxin dose, consider trying a different neurotoxin, different injection pattern, and then make sure that there isn't apraxia present.
Okay. Ben, if you have a patient who has MEJ syndrome, where do you inject them? How do you treat them? What do you do?
So I think getting into the lower face can be problematic. Not that I don't do it. I mean, I treat a lot of hemifacial spasm as well. Sometimes when you reduce the spasms around the eye, you reduce the spasms elsewhere. So they may be reduced, they may not go away. If that's not adequate, I may clearly put Botox in other areas, but you have to be so careful about dropping the lip. People end up biting the lip, their speech gets slurred, they're very unhappy when that happens. So I do things, but I do them very gingerly.
Is there any place in the lower face that you don't inject?
No, I've done orbicularis oris and mentalis and rhizoris and buccinator. I mean,
Now, Don, after you do a myectomy in someone, in this patient who has MEJ, do you ever find that the orofacial aspect of the MEJ gets better after you've taken care of the blepharospasm? And that'll go for injections as well as the myectomy.
Yeah, I'm trying to think back. I might have had, first of all, myectomy is not a very common procedure. Probably in my career I've done, 30 or 40 cases. And I think, if you look at the overall number of patients that require it, it's nationwide, it's probably not that many. So I can maybe think of only a handful of MEJ patients that have had myectomy, and I can't recall much influence of the procedure on the lower facial movements.
Russ, what about with injections?
Well, yeah, I have seen a few patients who had MEJ syndrome, and one in particular clearly had it. She got injected, I think, twice in her lower face, in addition to having periocular injections, and her MEJ seems to be completely gone. Sometimes I wonder if I see a trace of it. I have another patient that I've been treating for 20 years probably, who had MEJ syndrome early on, and I'm sure I haven't touched her lower face in more than 10 years. And her eyes still...
Yeah, I think you have to make sure that it's truly MEJ. I mean, if someone has severe blepharospasm, and I've seen this, is that they use all of the muscles of their face to try to get their eyes open. So sometimes some of the lower facial muscles is not really MEJ, and you take care of the blepharospasm, and a lot of this sort of lower face stuff will go away.
should we ask our audience?
Sure.
How
What do
many
you want to
people
ask
here
them?
have MEJ syndrome? And do most of you get your whole face treated or just around the eyes? Let me ask that direct question. So how many of you that do have MEJ that are treated with Botox just get the eyes and find it satisfactory?
How many don't?
So those of you out there usually get the lower
Small
face
end.
too.
Okay. So,
You got a comment over there, Peter?
So, my experience is that I've never been diagnosed with type 2 diabetes. At first, I didn't want to go that. I really went down my face. And now that I've had successful Botox treatment to another practitioner, this major effect has gone away.
yeah, and I think that happens with people. I've seen it happen. I don't know exactly why. This is for Dr. Edwards or Shari. I've heard that the more eye drops you use, the more you need them. Is that true?
Not really. In a way, the eye drop effect goes away shortly after, so it's just the lubrication. Just like cream on hand, dry hand, it's similar to that.
I think that might have to do with the drops that have vasoconstrictors in them take the red out. When you use that a lot, then you have rebound, and you'll never get rid of your red eyes. You have to continue. Same thing with nasal sprays. But just plain lubricants, not a problem.
Dr. Kikkawa, this is a patient who has injections, and I don't know if they get injections just around the eyes, but says that after the injections, the upper lid stays flat when they smile. I will tell you, whoever you are, is change doctors. Dr. Lee and Dr. Harrison are two hacks. They're excellent, excellent physicians up in Minnesota. So you're in good hands, all right? So they know what they're doing. Have you seen that if you inject just around the eyes, that it affects the upper lid? Lip.
Lip. I think the lower injections, yeah, I have seen that, particularly in cases maybe when we're trying to target these lower facial muscles in Meigs syndrome, that you get the lip elevator, yes, you can get the lip droop. If you're targeting the orbicularis muscle, I don't think it's very common, but
Yeah.
certainly if you're targeting the lower facial muscles, that we see that.
I've seen it once. I was in the original Dysport study, and one of my patients, and we didn't inject the lower face at all, we just injected around the lid, and one patient had sort of flattening of the lip.
There can be drift, migration of the fluid that we inject, and so I suppose if a person had enough volume or they just happen to have tissue planes that were most amenable to it, that some of the medication could diffuse low enough that they might have some effect on their mouth.
So going back to our previous comments from before and our previous advice, we would have this patient go home and stand on their head
Right.
for an hour.
Yeah,
and this
gravity
way-
boots.
Okay.
Inversion boots.
Can Botox injection, Dr. Wu, cause damage, permanent damage to the muscle?
Can Botox cause permanent damage to the muscle?
The short answer is not clinically. There's well-documented cases of people getting injections well over 20 years, repeatedly every 3 months, and really having no histologic significant damage. The Botox does cause, the botulinum toxins do cause denervation of the muscle, which you can hear on muscle EMG when you're injecting, and it does have to regrow every time, and you kind of wonder what that does to the muscle over time. Because there are histologic changes there are changes microscopically that happen every single time. But as far as with my clinical hat on, the answer is no.
I think there was a study a long time ago looking at the force that a person can generate with their eyelids using some kind of a spring transducer, and found that after repeated injections of Botox, the force they could generate was lower than what it was as a control, but that clinically it had no impact.
I thought there was a histopathologic study that shows that after long-term injections you do get some changes in the muscle, but I could be wrong about it. But again, it's not clinically relevant. Yeah. Ask them what, Nerlin? Control. No, we're talking about weakness. And I don't know. Yeah. Right, and I don't know, but I don't know, what we've said is that if it does cause any damage, permanent damage to the muscle, it's at a microscopic level that is not clinically significant. So I don't think that, it would be difficult to tell if your muscles are any weaker when you have so little damage over years and years and years. Does anybody think their muscles are weaker? Well, yeah, but they're not, that's part of the process, yeah. All right, now, if you see a patient who has blepharospasm and they have dry mouth, Dr. Afshari, is that due to the blepharospasm or something else?
Well, so there is a condition called Sjogren's syndrome, which is dry eyes with dry mouth. So people can have dry eyes and other inflammatory components. I would work them up for antibodies, and I would work them up for Sjogren's syndrome. There are also rheumatologic disorders that cause dry mouth. So, so dry mouth, when it comes with dry eyes, it needs a little more workup of blood work.
Yeah, dry mouth, you have to think about Sjogren's. Now, someone wrote a question, what's DBS? Someone asked.
Deep brain stimulation?
Oh, deep brain stimulation.
Yeah.
Are you going to try that, Drew?
What's the question?
What about deep brain stimulation for blepharospasm?
Right. I mentioned that very briefly.
Yeah, I know.
So, to my knowledge, I don't think there's been a case of deep brain stimulation, a surgical procedure where they put an electrode into the basal ganglia, which is a pretty deep part of the brain, kind of the peach pit inside the peach. It's very deep. It's used to treat Parkinson's disease, and it's been approved as a compassionate use for generalized dystonia. So I'm not aware that it's been used in isolated blepharospasm. I do know that it's been used in severe refractory cervical dystonia and Mage syndrome.
Why would someone with blepharospasm be unable to talk without eyelid drooping, but drive, read, watch TV is almost impossible?
I think those are the things that we, at least I find absolutely fascinating. That one of the things about dystonia is it can be very task specific, and the brain chooses which programs, which sets of muscles are required to do a certain task, and the dystonia affects only selected programs. So it's not a muscle disorder; it is a motor program disorder, and so I do not find that exceedingly unusual, but would try to learn from it.
Can I follow up on that question, Alan? Is that, so is it task specific, or is it the muscle movement direction specific? So is there certain tasks that require the muscle move in certain specific way that is a specific, because why would the brain know that it's watching a movie versus driving, but it's just different movement orders?
It actually can. So writing dystonia is probably the most dramatic one, where I will see someone type fluently but not be able to write. It is the same muscle movements that are required for both. I'll even have them type, and musicians' dystonia is the other one, where people who play piano or flute or guitar very fluently or at a very high level develop dystonia just for that task, even though those very muscles are used very similarly for typing and writing, and they are not affected.
But is it the muscle at that point, or is it now the brain, because one is writing, one is actually typing?
Well, if the muscle is working okay, I mean, the muscle works okay, if you test the muscle individually. So the muscle directions all work and are connected to the brain. It's only when the high-level program imposes itself that you get that muscle behaving inappropriately for that context. And that's what I think makes dystonia very interesting.
But, and that question, I mean, that's one of the things that I've learned, is that there are certain tasks that people who have severe blepharospasm can do without any difficulty, and other, my patients, one of the worst things for them is driving. But I had one fellow who just loved to drive, and he said, I can do that without any problem. I had one man who actually used to build these ships in bottles, all right? And his wife said he would stay in their basement and he'd build these ships in bottles, and he never had blepharospasm. He came up and talked to me, and he's got blepharospasm. Well, I said, well, you know, maybe you're the problem, you know, but it is task specific. It is interesting. It is interesting. Why is it that you can do some things without your eyes closing, yet other things you can't do? Yeah, but you scan, if you're reading, you're scanning, and if you're driving, you're scanning, and some people can read and not. So, yeah, so it is. Now, I saved the last question. This is the last question. There were several of them, and we'll go through the panel. Why does light sensitivity such a major component in blepharospasm? Major aggravating component. Is the blepharospasm causing the light sensitivity, or is the light sensitivity causing the blepharospasm?
I think Dr.
This is
Wu
this is a Nobel
Yeah.
Prize question.
and that's why I'm going to answer it this way. I think Dr. Wu knows the answer.
Could I just give a real simplistic answer?
What's that?
Can I give a real simplistic answer?
Sure.
I mean, I think there is a blink reflex to bright light. I mean, we know
Sure.
that that's part of the brainstem response. So, I mean, I'm sure it's tied in there somehow. We'll get the complicated answer now.
No, I was going to say exactly that. I think Natalie's slide where it said blepharospasm goes to dry eye or dry eye goes to blepharospasm, you know, the reality is our brains operate not in single reflexes. You know, we don't go through life getting zapped by bright light or getting zapped by electrical stimuli. It's a real-time phenomena that's constantly going on with every single blink of the day. And you know, the dry eye and the blepharospasm form its own loop. And I think that loop reinforces itself in patients with blepharospasm. So my simplistic view, and it is a simple one, I think there's a lot that the ophthalmologists have to add to all the wavelengths of light and the tear films and all that, but my simplistic view is that, yeah, there's a loop that involves with bright light sensitization in the blink reflex.
Ben, you want to?
Agree.
You agree.